Welcome to Lactation Education for Healthcare Providers. This module is entitled Breastfeeding General Knowledge. My name is Kara Rick. I am a Doctor of Nursing Practice student at Arizona State University, specializing in family care. I have a keen interest in breastfeeding medicine and providing care and support for mother-baby dyads. I am also a La Leche Legal Leader and a certified lactation educator.
My name is Marissa Honey-Jones. I'm an international board-certified lactation consultant, and I am also a La Leche League leader.
So to begin, I want to go over some of the objectives for this module. The objectives are to describe proper breastfeeding terminology, breast anatomy, and infant suck skills. To be able to identify steps listed in the Baby-Friendly Hospital Initiative and the role nurse practitioners and providers play in breastfeeding. To describe the role of the IBCLC, otherwise known as the International Board Certified Lactation Consultant, and how to utilize them as a part of the health management team for caring for mother and baby and the mother-baby dyad. And lastly, to identify community resources designed for moms and babies to help support and care for the breastfeeding dyad. So let's get started. First, we're going to talk about breastfeeding recommendations. And the recommendations we provide here are evidence-based recommendations. So there is, literature out there, there are guidelines out there that really talk about this information. And the reason why this is important is to make sure that you're providing the best evidence within your practice. So first thing we're going to talk about is feeding and duration.
So exclusive breastfeeding is recommended for the first 6 months of age. And exclusive breastfeeding means that there are no other foods or liquids given to baby. Culturally sometimes different traditions provide for other kinds of things for babies, and certainly be sensitive and knowledgeable about those in your practice and in your community. But we know from evidence that babies do best when they are exclusively breastfed for the first 6 months. Also, there's sort of a persistent notion that babies need additional water, especially in summer, and breast milk provides plenty of that as well. So also, to continue to breastfeed for 2 years of age, that is recommended both by the World Health Organization and the AAP, and then really that duration can continue for as long as it is mutually desired by both mom and baby. Infants should be fed on cue or on demand, so when babies are hungry, they're letting you know through a variety of ways.
So infants should be fed on demand. And so really what this means is that infants should not be put on a schedule. And think about a baby. Does a baby know what 2 hours is? Does a baby know what 3 hours is? No, babies know when they are hungry, and when they are hungry they begin to send us cues of chewing on their hand and starting to fuss and eventually starting to cry because they're trying to tell us that they need something. And think about you. When you are hungry, you can simply go up and eat some food, but a baby certainly can't say, Mom, I'm hungry, Mom, feed me. And so they start to send us these cues, and be mindful of what those cues are and tell your patients they should breastfeed on demand, because this is what the perfect breastfeeding relationship is. One other thing I want to talk about exclusively breastfeeding to 6 months of age. This is really important because within the first 6 months of age, the research tells us that if we are exclusively breastfeeding, we are helping baby to develop an awesome immune system. We are laying down appropriate gut flora, and this breastfeeding is going to help serve the baby for the rest of their life. The exclusive breastfeeding helps to decrease asthma, decrease ear infections, upper respiratory infections, and whatnot. And so babies don't need to have any food until they're 6 months of age, because breast milk is providing everything that they need. So now we're going to talk about complementary foods and when we should introduce them.
So complementary foods should be introduced at around 6 months. Research shows us that the prior recommendations for maybe 4 months that kind of persist, really we should be looking for more of a 6-month mark, right around the middle of the first year. And we're also looking not just for that age, but for real readiness factors from baby. Baby should be able to sit up well and unsupported and to have lost the tongue thrust reflex. Baby will also ideally exhibit this pincer grasp, the ability to start grabbing at pieces of food and really be interested in engaging in that meal time as well. Food should be complementary to breastfeeding. The idea isn't to move from primarily, exclusive breastfeeding into mostly solid foods. This is really the beginning of a transition, and for a long time, breastfeeding will still be the primary source of nutrition. And complementary foods should be whole foods to cover a variety of nutritional needs. We're looking for something that's nutrient dense, that isn't just sort of a filler food. And ideally, these are also things that families are eating in their own meals that babies can try pieces of or portions of as appropriate.
Babies should be showing readiness for this. So if they see your mom and family eating, if they're reaching for food, certainly don't share with them what you're eating. Share with them at the family and make them a part of family eating. It shouldn't be something where baby is requisitioned off on their own. There should be a family time to come and share food together. So talking about weaning.
So weaning is something that does begin with the introduction of complementary foods, but takes place again over ideally quite a long time. It's something that should be decided mutually by mom and baby. There should not be interference with that process. That's going to be different for each family and each breastfeeding dyad. Worldwide, the average weaning age is between 2.5 and 4 years of age. So we know culturally that that's not what we're always seeing in the United States, but as a biological norm, breastfeeding in humans is generally from about 2 to 7 years of age. So we're looking to satisfy that need for as long as we can support mom and baby in that relationship. The other thing is that weaning, again, should be a gradual process and not something abrupt. This is a benefit both for mom and baby. For mom, the sudden cessation of breastfeeding puts them at risk for plugged ducts, mastitis, infections, maybe even leading to abscess. But breast infection is a serious risk and nothing to take lightly. So helping mom through that process, if she should need to wean for a particular reason, is important. But ideally, this is something that, again, takes place over time. The other thing it's important for baby to have that time for weaning as well. This is an emotional need for them. Breast milk just isn't meeting the need for food or nutrition. It's also meeting a need for close contact and an interaction with mom.
Right, so within your practice, make sure that you're not telling mom, oh, your baby's 1 year old, you should wean them, or you should wean them abruptly, or you should just stop right here. Weaning, as Marissa pointed out, is a process. It should be started slowly. It should take a period of time, and it should be individualized for each mother-baby dyad. So everybody's weaning journey is going to be different. There's no one set way. There's no one set time, and it's really what works for that family. And this leads perfectly into family counseling.
Yeah, so one of the most important things that we know that helps both the initiation rate and the duration of breastfeeding is counseling prenatally. So in practice, start discussions with your patients about what their plan is, about have they thought about breastfeeding, or what have they thought about breastfeeding, what do they know, to be able to give them information. Involve partners in that discussion or other people that are close in the family that may have an influence on mom and help them to understand as well. It's often these days that mom comes to an appointment with her partner or another member of her family, and have information and address those people as well who will be her key supporters. Promote breastfeeding within your practice. Make sure that you have not just words and information, but also images of breastfeeding. This is the biological norm, and to present it as well as the cultural norm is something that we know is very helpful. It's also helpful to help moms develop a breastfeeding plan. It is fairly common these days for moms to have birth plans or make their birth wishes known wherever they're going to have their babies, but it's also a great idea for them to be able to say what they would like for their breastfeeding relationship, and that they would like to exclusively breastfeed, maybe not be separated from baby at all until after the first breastfeeding has taken place, that they don't want artificial nipples or pacifiers of any kind. Hospitals who are focused on baby-friendly initiative are not going to be doing these things, but that certainly doesn't cover all healthcare facilities. So helping them to develop a plan to meet that goal is important. And also, consider how much effect that formula advertising has on a mom. In a practice, it is very influential. All those messages that come from pens and clocks and bags with coupons or samples are highly influential in a time where moms are very susceptible to the kinds of messages they're given, and not advertising formula shows your commitment to supporting breastfeeding.
And I want to touch on that too. So the research tells us that when providers actually have a stance on breastfeeding and they're promoting breastfeeding within their practice, patients are more likely to initiate and continue breastfeeding. So if you have a patient that comes to you that's either on the fence or really considering formula feeding, and your stance is to support and promote breastfeeding, you're more likely to change that mom's idea and that mom's perception of breastfeeding so that they initiate, start, and continue to have an amazing breastfeeding relationship. So the message you send overall is huge, and that's why I put here to not advertise or offer formula samples within your practice, because this is sending a mixed message. So if you are saying, I support breastfeeding, breastfeeding is important, breastfeeding is best, and then you have a formula company clock on the wall, or you have a can of formula when patients are checking out, this is a mixed message, and parents don't entirely know how to read it. So make sure you're sending the message that you're supporting breastfeeding, and realize that it is the biological norm, and this is what we ought to be doing. So now we're going to talk about breastfeeding assessment. So what kind of assessments do you do in your practice when you are talking about breastfeeding? And a couple things here that I'm going to cover. I'm going to cover breast assessment, and I'm going to cover oral assessment. First, we talk about breast anatomy. And so you see the image here that outlines the different anatomical marks within the breast: the chest wall, the lobules, nipple surface, areola, fatty tissue. Important to know where that all of this is. What you want to do in your practice is perform breast exams both prenatally and postnatally. Prenatally, you want to make sure there are breast changes during pregnancy. So you, in theory, should see the breast becoming larger, you should see changes in the nipple, and you should see changes in the areola. The questions you want to ask mom are about if she's ever had any damage to her breast, has she had breast surgery, has she had implants placed in, because all of this can affect the breastfeeding relationship. Another thing you want to look for is flat or inverted nipples. If you know mom has a flat or inverted nipple, this can be a talking point for mom to be aware that breastfeeding might start off a little bit difficult, but there are ways to help this prenatally so that this first experience with breastfeeding is not frustrating and hard for mom. After baby is born, we should continue to do another breast assessment to see that milk has come in. We know that with lactogenesis, the first couple days and even before baby is born, breasts start to make colostrum. 2 to 4 days after baby is born, we enter what's called lactogenesis 2, and this is when copious milk production occurs. So we should have, mother's breast should feel full, mother should be able to feed the baby, and baby should ideally be satiated from seeking nutrition from mom's breast. If this is not happening, we know that we need to intervene. And there are other modules that have been created within this series that talk about treating low milk supply, reasons for supplementing with formula that you can access to get more information on that. Here we just want to talk about breast exam and breast anatomy. So talking about infant anatomy and the latch when baby is at breast, and certainly once baby is born, you're going to want to do a thorough examination, both of the baby's oral cavity and also, again, we talked about mother's breast, but what are we looking about for when we look at latch? Baby's lips need to be flanged to make a good seal. And why is this important? So think about a suction cup on a wall. If you have a little blip in that suction cup, air seeps in, and that suction cup comes off. Babies' their lips are similar. If there is not a good seal, air starts to come in, air goes down in the infant's tummy and makes their tummy upset. Think about how you feel when you have a lot of gas in your tummy. Not so good. And babies are the same way, but the difference with babies and us is that babies can't say, Mom, Dad, I have gas in my tummy. They are just fussy and upset and what we call colicky. Next thing we want to look at is that the nipple should be deep within the mouth, and it should be barely touching the soft palate. So if you look at the image I have here on the right side of the slide, you see a nipple in an infant's mouth, and you see where the nipple ideally should touch within the mouth. So if you're observing a breastfeed and nipple is continuing to fall out of baby's mouth, then you know that there's an oral issue with baby and that the nipple is not properly placed in mom's mouth, and this means that milk is not properly being drained out of the breast. Certainly mom is going to have letdown and baby's going to get milk some way, but the baby's mouth is not actually able to form a seal and drain milk from the breast. And if we don't correct this, we lead to low milk supply issues and damage to mom's breast in the future. The tongue of the infant should be unrestricted and able to peristalsis, which means, kind of like a wiggling motion, to transfer milk from the breast into baby's tummy. If the tongue is restricted, and this is where we talk about tongue tie, they're not able to do this. And so when you're doing an oral exam, you're going to want to see, is the tongue tethered down? Is the tongue able to lateralize? Is the tongue able to stick out of the mouth? There's another module that talks about tongue tie and ankyloglossia here that gives a more thorough assessment of the oral exam. But knowing what you need to do and what you need to look for now can be extremely helpful. Questions you want to ask mom is, how comfortable is it? Is breastfeeding painful for her? Does it, feel good? Does she have any damage to her nipples from breastfeeding? Is the infant able to release the nipple on its own? Is infant falling asleep at breast? And looking at weight gain. And these are all indications of how an infant anatomy is and how latch is. So signs of an incorrect latch. So things that we might see that are very observable if we're observing a breastfeeder in our office. Infants' cheeks during suckling should not be going in and out. So, kind of like making fish. You shouldn't see that at all with a baby, and that means there is problems with the fat pads. There should be no clicking noises. So if you have a baby nursing and you're hearing the means there is a problem. If the lip is curled inward on the breast, the baby's lips should be flanged out and should be surrounding the nipple to make a good seal. If the baby needs to be making swallowing sounds, so you can observe this by watching baby to make sure milk is being drained from the breast and baby is swallowing and getting nutrition. We talked about pain and discomfort by the mother. Late signs that breastfeeding is not going well, we see trauma to mom's nipples. So we may see pieces missing, which is really scary and hard for mom. We may see cracks, we may see bleeding. And really, if we observe latch early on, we should hopefully not get to that point. Another late sign, poor infant weight gain. So we see things like failure to thrive. We see babies that have high bilirubin levels. And this means that breastfeeding has not been going well for a long, long time. And we should have intervened before that point. And the ultimate result of all of this is low milk supply. Certainly we don't want to get here, and so we want to be doing breast assessment infant latch and breastfeeding assessment early on. And if this is not something you're able to do in your practice or you don't feel comfortable with, certainly employ the help of an IBCLC. IBCLCs are International Board Certified Lactation Consultants, which Marissa is, that actually have training in assessing latch, assessing breast, and assessing mother-baby pairs together to see if there is a problem. Then we talk about milk transfer. Is baby getting enough milk, draining enough milk from the breast? And what things do we see? Baby should have a coordinated suck, swallow, breathe pattern. So baby should drain milk from the breast should enter the mouth, baby should swallow the milk. And it's almost like a rhythm, like suck, swallow, breathe, suck, swallow, breathe. And you should be able to hear audible swallowing and see milk transferring down. That the sucking should begin rapidly because baby is stimulating a letdown from mother's breast. There should be a milk letdown for mom. Some mothers feel this letdown, some mothers do not feel this letdown. And then again, I talk about the rhythm, the suck, swallow, breathe for the milk flow. And there should be an undulating action of the tongue, or the peristalsis, which we talk about, the wiggling of the tongue to stimulate the drawing out of the milk from the breast. There should be no stroking, any friction. The nipple should stay in the mouth. It shouldn't be moving in and out if the tongue is able to properly latch onto the breast. If we start to see these things, then we know that baby has a latch problem, and chances are it's going to be pretty painful for mom. I mean, when mom is breastfeeding and the breast should stay in the mouth, and if it's moving around and there's friction and whatnot, mom's ultimately going to have nipple damage, and this leads to bad things. So looking for milk transfer, as I previously talked about, looking at the latch, these are all things that you should be familiar with as a practitioner and be able to do a basic assessment. And if you realize something is wrong, refer out and know your community resources so that we can save this breastfeeding relationship before it gets to be too late. So I want to touch on the negative impacts of not breastfeeding. So what happens if we choose not to breastfeed? If families choose not to breastfeed, society chooses not to breastfeed. In the United States, we have a call to action from our Surgeon General that says that we as providers should be promoting breastfeeding. There should be more education in schools. There should be more work done with the families, incorporating families, more education given to moms to support and promote breastfeeding within our community. So why is this important? This graphic here shows a difference between breast milk versus formula. So looking at breast milk, we know, and research tells us, I'm not even making up, this is honest to goodness research tells us that breast milk is providing the correct balance of nutrients for baby. There are immunoprotective properties, there's nutrients, there's over, I think they say over 1 million ingredients in breast milk. We don't even know. There's so many ingredients that go into the composition of breast milk that it's unbelievable. The science, they keep finding new things that are in breast milk to support babies all the time. Formula, we know, is a one-size-fits-all. Certainly formula companies choose to update their formula, but when you take a scoop out of the can, you know exactly what you're getting. And there are no immunological properties, and it's not formula fitted for that baby. Breast milk is formula fitted for that baby because what's really cool is that there are receptors on the breast. So when baby latches onto breast, it's sending signals to the mom's body, to the mom's brain about what this baby needs. Formula, unfortunately, can't do this. We know that there's specific health benefits to both mom and baby from breast milk. So we know for mom, just decreased risk of breast cancer, decreased risk of developing diabetes. Later on, we know for babies, decreased risk of ear infections, decreased risk for SIDS, decreased risk for enterocolitis, decreased risk for upper respiratory infections. Much research out there that supports all of this. We also know that for breast milk, there are no known linked health benefits. So we know for formula that when we are giving that to baby, there's nothing. There's certainly nutrients there, and we are providing nutrition to the baby. But this doesn't lead to decreased ear infections like we talked about, and there are no health benefits to mom for using formula. What we do know with using formula is that certainly there are cases when we have to use it. And these cases are probably minimal. The research shows that probably 5% of women truly can't breastfeed their babies. But the way that we are using formula now it's kind of out of control. Like, we know that from statistics that at least in the state of Arizona, at 6 months of age, only 10% of babies are exclusively breastfed. And there really is no need for this. When we start talking about breast milk, one of the, I guess we could call it a negative, is that mom has to be present or have pump milk to give to baby. And in some sense this is a negative, but when mom is breastfeeding baby, you're creating this awesome bond between mom and baby. You're developing psychologically for this baby that is huge. And even psychologically for mom is huge to have this bonding experience. And when we use formula, anybody can give the baby formula and it can happen at any time. Breast milk is free. We know this. The current cost, this is 2015, to feed a baby for 1 year of formula is $1,733.75 for just 1 year of formula. And certainly if people are on government assistance, they pay for some of that, but they don't pay for all of it. And know that this is just the cost for formula. This doesn't include the cost for increased doctor's appointments, other issues that may arise because we have chosen to use formula and we've chosen not to use breast milk. So the long-term impact of using breast milk substitutes. We just talked about a little bit about health impacts, that clearly breast milk creates a healthier community. There's a research article by Bartek and Reinhold that did an analysis of the healthcare system, and they found that if our society, or the United States alone, for 1 year, 90% of mothers exclusively breastfed their babies for 6 months, we would save $13 billion. We save money because we've decreased we've decreased ear infections, upper respiratory problems, we've decreased the likelihood of obesity, of diabetes, even decreased risk for allergies. So the benefits are huge, and the impacts both for our health and both socially are huge as well, because if we're saving $13 billion, think of where this money could go to. And this is cost to families, this is cost to the healthcare system. It could be all saved. We know that formula breast milk substitutes generates waste. Every time we buy a can of formula or receive it in the mail, I mean, that's another canister that goes to the dumpster. That's another piece of mail that comes in that we are creating more and more waste for. And social impacts. If mom isn't breastfeeding baby, and like I said, certainly there are times when this can occur, there's not this bonding. And the research is telling us that babies truly need to bond with moms and with their families in the first 6 months of life, that their cries are not cries for naught, that their cries are actually because they need something. And so breastfeeding helps to create this bond between mom and baby. It helps to generate trust, and this goes a long, long way in a baby's life. So now I want to talk about the International Code of Marketing of Breast Milk Substitutes. And this comes from the World Health Organization. This was adopted in 1981 by the World Health Organization. I think 118 countries voted for it, 3 voted against it, and 1 abstained from voting for it at all. What is the International Code of Marketing of Breast Milk Substitutes? It is put in place because it emphasizes that there is a need for education and information about infant and young child feeding, and for the establishment of measures at the government level to protect women against misinformation, and specifically misinformation about breast milk substitutes. The International Code also recognizes that inappropriate feeding practices lead to infant malnutrition, morbidity, and mortality in all countries, that improper practice of marketing of breast milk substitutes and related products contribute to this major public health problem. Please note that the World Health Organization's code intention is not to rid the world of formula, but it is to change marketing for formula. So think about the United States. And I'm going to point out right now that the United States is one of only 10 countries who has not adopted any part of the WHO code. And in the United States, we have formula marketing on television. We have formula marketing in the hospital. We have formula marketing in our providers' offices. We have formula marketing in the mail, on the internet. It's everywhere, everywhere. And there's nothing to stop it. And what does this information do? All this marketing serves only to confuse moms, especially when they're in a very vulnerable time in their life when they have a new baby, to send them misinformation. The woman's body does an excellent job of providing nutrition for a baby. There's usually no necessity to have formula introduced. And so the WHO code was put into place to limit the marketing of these products. So what is the summary of the WHO code? What is the aim of it? The aim is to protect and promote breastfeeding by ensuring appropriate marketing and distribution of breast milk substitutes, otherwise known as formula. Now, what is the scope? The scope applies to all breast milk substitutes, specifically formula, when marketed or otherwise represented as a partial or total replacement for breast milk. And it also applies to using feeding bottles and teats. The WHO code outlines that there should be no advertising of breast milk substitutes, bottle feeding, or teats. No free samples should be given to mothers or their families or healthcare workers. No promotion of products, which means product displays, posters, or distribution of promotional material should be used or presented in a public forum. And similarly, company paid personnel should not be out promoting and pushing these products. No gifts or samples should be given to healthcare workers, and product information should be factual and scientifically based. There should be no free or low-cost supplies of breast milk substitutes in any part of the healthcare industry. Now, clearly, when I read these examples from the WHO code, we know in the United States we haven't done this. And so why am I telling you about this? I'm telling you about this because know that the United States is one of the only countries that hasn't implemented this, and we as healthcare providers, knowing the benefits of breast milk, knowing the benefits it provides to moms and babies, knowing the social benefits, we should be advocating for this WHO code to be adopted by the United States. And as practitioners, we should be taking a stance within our practice not to be offering formula, not to have promotional products, and sending the message that we support breastfeeding. So why is this important? Globally, we know that breastfeeding has the potential to prevent 800,000 deaths of children under the age of 5 years of age if children between 0 and 23 months were optimally breastfed. Currently, exclusive breastfeeding rates worldwide are only at 38%. There are 30 studies worldwide that have shown that breastfeeding reduces the risk of dying before the age of 5. So we know, and I've gone over some of these benefits of breastfeeding, we know that they're there, and it's saving lives. Breastfeeding saves lives. Specific to the United States, I've talked about the research by Bartek and Reinhold that if 90% of all infants were exclusively breastfed to 6 months of age, 911 infant deaths would be prevented, and the U.S. healthcare system could potentially save $13 billion per year. I don't know about you, but that number is huge to me, $13 billion. So we talk about health benefits to mom. We talk about decreased breast cancer, decreased likelihood of diabetes, decreased obesity, decreased ovarian cancer. We talk about health benefits to baby, and I have addressed a lot of these. Decreased ear infections, upper respiratory infections, stomach illness, stomach bugs are decreased, and SIDS. Breastfeeding reduces the rate of SIDS. So, status of the WHO code. As of 2015, the United States has taken no action to adopt the WHO code. We are part of only 10 countries who have not taken any action. To give you an idea, Canada has a few of the provisions of the WHO code enacted into law, and Mexico has many provisions enacted into law. So this is just in North America alone. Our neighbors to the north, our neighbors to the south have adopted parts of this WHO code, and we haven't done anything to prevent marketing of breast milk substitutes. The United States is one of the only countries in the Americas that does not prohibit the advertising of breast milk substitutes and allows for materials and gifts to be given by formula makers to healthcare facilities. And to me, this is sad. Like, we are a first world country. We talk about our liberties. We talk about the great healthcare system that we have. we should be enacting this WHO code, and we shouldn't allow these formula companies to railroad breastfeeding to send the wrong message to moms, because so much research is out truly supports breastfeeding. And like I said, I know there are cases where we have to use formula, certainly. But the way we are marketing it now makes it seem like every mom needs formula for a baby, and this is not true. This is the wrong message, and ultimately this is leading to health disparities within our society and the United States. So how does the WHO code affect you? So I want you, and by watching this video, certainly you recognize the importance of breastfeeding. You recognize the health benefits to mom, the health benefits to the baby, and socially the health benefits. You should understand the negative role that marketing of formula plays on breastfeeding. Think about the message we're sending. I mean, think about a family practice office that we promote wellness, correct? So if we come into the office, how do you think a patient would perceive us if we're selling French fries? Certainly that's sending the wrong message, because we know that French fries are not healthy. I don't promote for my patients to eat French fries, and I'm sure you don't either. So formula is somewhat in the same idea, that formula is inferior. Formula causes problems. We should be promoting breastfeeding. Part of the WHO code, I'm asking you not to offer free products within your practice to families. I want you to encourage breastfeeding among your patient population and send the message that you are supporting breastfeeding. And work to educate yourself and communicate the benefits of breastfeeding to all patients and other providers in your community. We know the benefits of breastfeeding, and it takes, one person continues to grow. So I'm sharing this message with you. You continue to share this message with other people so that we start to see some change, and hopefully the United States will enact the WHO code within my lifetime. So Baby Friendly Hospital Initiative. What is the Baby Friendly Hospital Initiative? This is another initiative that was launched by the World Health Organization and UNICEF in 1991. This is a global effort to implement practices that protect, promote, and support breastfeeding within the hospital. And I want to point out here that the Baby Friendly Hospital Initiative is growing. So in Arizona, which is where we are, there are actually 5 hospitals that have enacted or received Baby Friendly Hospital status. And there are several others that are going for it, specifically here in Phoenix. Mercy Gilbert Hospital is one that is in the process of getting Baby Friendly certified. So it's something that's growing and changing, and you should know about this for your practice, if you're practicing in these hospitals, if you're involved in these hospitals, to know what is the Baby Friendly Hospital Initiative and how does it affect you. So there are 10 steps to the Baby Friendly Hospital Initiative, and I've listed them all here, and they call it the 10 steps for successful breastfeeding. The first is for the hospital or facility to have a written breastfeeding policy that is routinely communicated to all healthcare and staff. So that means that the facility has something written out that talks about where they stand on breastfeeding, certainly supporting breastfeeding, and that all of their providers, nurses, physicians, nurse practitioners, everybody should be supporting and sending the message of breastfeeding. That all healthcare staff should have training on the implementation of this policy and the skills necessary to implement this policy. So even in a hospital, the emergency room, providers have to take classes to inform them about breastfeeding. And so the emergency room should be providing breastfeeding support. They should have some knowledge on how to promote breastfeeding. Once an infant is born, mothers should have help initiating breastfeeding within 1 hour of birth. All pregnant women who come to the facility should know the benefits of breastfeeding and how to manage breastfeeding. Mothers should know how to breastfeed and how to maintain lactation within their body, even if they're separated from their infants. So that means that we're talking about pumping, we're talking about hand expression, we're talking about breast massage here. Infants should not be given any food or drink in the hospital except breast milk, unless it's medically indicated. So certainly there are going to be cases where we have a preterm infant or a mother who cannot produce milk that we're going to have to use formula, but these are medical issues, and it's not really a matter of choice where mom says, oh, I don't want to breastfeed, because we're promoting breastfeeding within the hospital here. Practicing rooming in, that means baby is staying in the same room with mom, and they remain together 24 hours so that we are fostering and supporting that breastfeeding relationship. We are encouraging breastfeeding on demand, and I talked about this before, that babies don't understand time. We are not putting babies on a schedule. Babies are sending the signals to feed, mom is reading these signals, and we're feeding baby. Pacifiers and artificial nipples are not given to infants and to breastfeeding infants. And the reason really this is that I want to touch on this, because some people don't entirely understand, is that when we introduce a pacifier or an artificial nipple early on in the breastfeeding relationship, that's time that the baby's not on the breast. And within the first 6 weeks of a breastfeeding relationship, that's the time when a mom's body is developing her supply. So if baby is sucking on something else when they would rather be seeking nutrients from mom, the body's not receiving those signals, we're not developing a strong milk supply, and this leads to problems later on down the road. So the last point of this is that the hospital is fostering the establishment of breastfeeding support groups and referring mothers to them on discharge from the hospital or the birth center. So within our community, and within every community, there are certainly many breastfeeding support groups. There's LA2 League International, there's Breastfeeding USA, and we talk about these at the end of this module here. But we want to foster these, and we want them to grow. We want to send mothers there. We want mothers to know that they're not alone, because setting up the support system, like I talked about in the beginning, is huge to moms, to know that they're not the only one experiencing this, to know that there are people that are out there that want to help them, that they can communicate their needs within a friendly group setting, so that breastfeeding does not become difficult, that we are preventing things like postpartum depression, and that we are providing babies the nutrients that they need. So how do hospitals obtain breastfeeding hospital initiatives? Babyfriendlyusa.org is a website that you can go to if you want more information on this. And they've actually provided this lovely diagram here that kind of gives you an idea of how a hospital becomes baby-friendly designation. It's not something that happens overnight. It actually takes a couple years for a hospital to go through this process. In some hospitals it takes longer. There's a discovery period where hospitals say, okay, look, we want to be baby-friendly. We want baby-friendly status. They develop a plan to implement this. They start training employees. They come up with the plan that was first mentioned for employees to read, and then they disseminate this information. So staff needs to be trained. They need to collect data to ensure that people have obtained the proper education, and then they have there's a site visit from people who certify their facility as baby-friendly, give them the baby-friendly status, come and visit the facility to make sure they've gone through all of these steps. And why is this important to you? You may be involved in a hospital that's seeking baby-friendly status, and if you're not, you can certainly promote this. You can be part of this discovery phase and this development phase, because ideally all hospitals should be baby-friendly. All parents should have a place to go where breastfeeding is promoting breastfeeding in our practice. We're all sending the same message. And going back to talking about the WHO code and not offering samples, we know in the hospital, and baby-friendly hospitals even have higher initiation rates, but currently as it stands, 83% of women initiate breastfeeding in the hospital. Statistically, throughout the United States, at 6 months of age, only 26% of women are still exclusively breastfeeding. That is a huge drop, because moms leave the hospital, they don't have the support they need, they're not getting support from their providers, and so then breastfeeding doesn't work out as well as they wanted. And so baby-friendly hospital initiative, adopting the WHO code, going into your practice to support breastfeeding will help to increase those breastfeeding rates, and especially exclusive breastfeeding rates. So what is your role as a practitioner? Certainly educate yourself, and by watching this module and other modules in this educational series, you are educating yourself, and I want to thank you for doing that, because that's huge. Play an active role in promoting breastfeeding pre- and postnatally. So again, we talk about sending the right message within your practice. Not having formula offerings, not having advertisements from formula in your office, but having breastfeeding material, pictures of women breastfeeding, talking about breastfeeding, helping patients create a care plan. Educating other practitioners. So clearly we are here now to educate you, continuing to take this message and share it with other people, that we want to promote breastfeeding, and your attitude towards breastfeeding makes a huge difference. And I already talked about that a little bit, But patients look to providers for information. They look for you for trust. They look for you for support. And so the message you're sending truly does matter. Community involvement to make breastfeeding the norm. So in August is World Breastfeeding Week. You can help to arrange community support, community activities to support breastfeeding, to send the message to support moms, to support babies. So what is a practitioner's role in breastfeeding? And certainly throughout this entire talk, I have talked about practitioner's role and the role you play. And this is just going to kind of go over a little bit of that. So first, looking at education, staying abreast on breastfeeding research. And there are research journals, Breastfeeding Medicine, Journal of Human Lactation, that are published that present monthly research that's going on in breastfeeding. The Academy of Breastfeeding Medicine is a professional society of doctors, nurse practitioners, IBCLCs, dentists that have come together to support breastfeeding. And they have protocols that they have published that present evidence-based information on breastfeeding. There are over 20 protocols that talk about treating and caring for the mother-baby dyad. There's a picture here of a book by Dr. Ruth Lawrence that is specific towards breastfeeding that you can purchase off Amazon and have in your office. To look up material if you get a situation that you don't know the answer to, you're a little confused. This is an excellent reference manual for you to use in your practice to look up breastfeeding information. And also, Academy of Breastfeeding Medicine has doctors on there. They actually have a listserv if you join up that you can become part of to create a dialogue with practitioners if you have a patient to troubleshoot, or if you just want to be among other practitioners that support breastfeeding. Be mindful of your patient population and be mindful of the message you're sending. And certainly, this is, we're starting out small because we know breastfeeding is something that we need to grow, and this is part of the Healthy People 2020 initiative. But you play a role in promoting breastfeeding within your patient population. And so the message you send to them is important. I can't say this enough. Your message of communicating that we support breastfeeding, we want breastfeeding, breastfeeding is wellness and leads to optimal health. This is your job, and you should embrace this, and you should be proud to support breastfeeding within your practice. So breastfeeding promotion. I just talked about the message you send to your patients. Make sure that the message you send reflects evidence-based research. And so oftentimes we get caught up in our own culture and our own experiences with breastfeeding, and there's so much research out there that's going on. There's research going on at Arizona State University, the school I'm part of. There's research going on UC San Diego. There's research going on all over the United States on breastfeeding medicine, breastfeeding research. And so keep abreast on it. And if you don't know, certainly look it up. There are plenty of databases, PubMed, CINAHL, and whatnot that you can go to look up your question and find the answer to. Know that patients make decisions based on their provider's recommendations. So if you are supporting breastfeeding, guess what your patients are likely to do? They're likely to breastfeed. If you have that can of formula sitting on the counter in your office, you're sending the message that you support formula, and that's not what we want. And be aware of community resources, and certainly I will go over these at the end, talking about La Leche League and Breastfeeding USA. Know that they exist, know that there are free resources, and refer patients there often. A mother who's pregnant can really benefit from going to a La Leche League meeting or Breastfeeding USA meeting, because that helps them to formulate this plan. We talk about patients about having a birth plan. You should have a breastfeeding plan as well to implement, so you have an idea of what you want, what you don't want, and how that's going to work, and how it's going to work with the family, with the provider, with the hospital. Dissemination to colleagues. You play a role in the social perception of breastfeeding, and so certainly, breastfeeding is starting to come back into popularity, although I'm not entirely sure why it ever was not popular, like how we got onto this point where we were prescribing formula when we know that it's not beneficial to babies. But you play a role in talking to your colleagues about the importance of breastfeeding and supporting breastfeeding within their practices. And education starts with you. The Academy of Breastfeeding Medicine is an excellent resource that you can go there. You can get a membership. You can connect with other colleagues in your area. You can look up other colleagues, and forming community and just having these conversations. And educating yourself on the protocols and the evidence-based material. So now we're going to talk about the role of the International Board Certified Lactation Consultant. I'm going to leave this up mostly up to Marissa. She is an IBCLC. She is very well respected within the lactation community, and she has a lot of great information to share with you.
So the background of the IBCLC, we are governed by the International Board of Lactation Consultant Examiners, and we are internationally board certified. That board certification requires a number of facets of training and experience. First of all, it requires 90 hours of lactation-specific education, additional college classes, or a background in a specific set of college courses, and up to 1,000 clinical hours depending on the pathway. IBCLCs are also required to recertify every 5 years, and we have a professional organization that is the International Lactation Consultant Association, and the goal is to work to protect, promote, and support breastfeeding. Know that there are many kinds of breastfeeding helpers in the community, and that the IBCLC is the professional credential for our specialty. We have a clearly defined scope of clinical competencies, guided by standards of practice, a code of ethics, and we work within a scope of practice. We actually take a board certifying exam just like a nurse or a doctor would do, helping dyads to initiate and sustain breastfeeding in complex situations and for a variety of unique needs.
Right, so know that the IBCLC wants to be part of the healthcare team, and so IBCLCs are there in addition to doctors, in addition to nurses, and they have a very specific role in the breastfeeding relationship. They're here, they have appointments, and they are able to do assessment just as MD is, but they have specialized knowledge. They say a master's level specialty in their field to help provide care and support for the breastfeeding dyad.
So helping patients with breast conditions, what an IBCLC does is assessment of both mom and baby. We will assess anatomy of each and watch a feeding to observe what happens over the course of that feeding. We support moms with lots of evidence-based information, and we talk about positioning and latch. Sometimes breastfeeding problems have simple solutions. Moms need to see it and to be helped to have a proper latch, have good positioning. We also can teach moms how to do breast massage or hand expression to avoid some of the problems that can occur with plugged ducts or mastitis, things that when there is not good milk removal, when there's not efficient milk removal, problems that can occur. So we can help to avoid those. And we do all kinds of other things as well. But our information is based on evidence-based. We're focused on evidence-based practice.
Right, so know that they have specific training in this area, and Marissa covered this in the previous slide, but they take 90 hours of lactation-specific education to learn about the assessment, to learn about providing support, to learn about positioning, and then they have an additional clinical hours, and in some of the specialties up to 1,000 clinical hours where they have actually spent doing the assessment, providing support, providing position. So they are truly experts in this area. So utilize them within your practice, utilize them within your community, and create great relationships with them. They want to work with you, and they're really here to help and support you and help support this breastfeeding dyad. So talking about community resources that are available, and I know that I've talked about this throughout the different throughout this module here, and so this is the specific area where I'm going to list them out. The two community resources that I have listed here are La Leche League International. La Leche League was started in the 1950s by a group of women that gathered in their home to form communities to support breastfeeding, and now it has grown worldwide. So there are La Leche League meetings all over the world in multiple countries for the sole purpose of supporting breastfeeding. And we know, and the research tells us, that breastfeeding support is huge for the continuation of breastfeeding. So moms having this peer-to-peer support, being able to talk about their issues, being able to have somebody to help them, having other moms to help them is very important. Breastfeeding USA is a more recent organization that's developed, but they provide the same sort of support. They have meetings in different countries, and they are continuing to grow. The one thing to note is that leaders within these organizations, both La Leche League and Breastfeeding USA, go through specific training. So not anyone can become a La Leche League leader. Marissa's a La Leche League leader. I'm actually a La Leche League leader. And we've had to go through several hours of training to be able to have this position to help moms and families. And the same thing is true for Breastfeeding USA. And you can contact both of their, I've provided the web addresses here to go for La Leche League to find your local meetings to refer moms to, and the same thing with Breastfeeding USA. So this is the conclusion of our talk. I hope you've gained some knowledge on general breastfeeding for assessment and skills. Thank you for viewing this module, and thank you for playing a role in supporting breastfeeding. Please take the post-test and complete the evaluation if you're seeking continuing education hours.